Hello there, guys. This is Benjamin with EMT Booster today. So what we're going to be reviewing today is the operations review. So a lot of this is just going to be reviewing a document. So if you guys would like me to change it up or add things, I will. But yeah, here we are. So the first thing, the priorities to have as soon as you arrive on shift should be done prior to running an emergency. So stock and check your rig for supplied equipment, things like catheters, um, A- AED, all that good stuff. Then check your rig for any sort of mechanical failures like low gasoline, burnt oil, tires are bald, whatever. You just need to make sure that you're not going into the world unprepared, because 95% of the time, if you're going to a call and you forget shit, it's going to be a really bad time explaining to someone that you forgot a life-saving item. So it's always good to just make sure you have every item that is on your list of what you need as a BLS provider. How do we approach school bus that has its warning lights on? Stop. You're not allowed to pass. It's just the same as anybody else. It doesn't change. Um, when considering air transport, what type of patients are in most need of airship? So patients with time-dependent illnesses, stroke, acute MI, spinal injury, venomous bites. So things that, if you're in Bumfuckistan, Colorado, and you've got a patient who got bit by a diamondback, for example, and it's been 2 hours since EMTs responded, and he needs to get to the hospital within the next set amount of time. If he's in the ambulance, he'll probably start exhibiting symptoms and start going into some sort of shock, then presumably cardiac failure and death. So any sort of situation where time is critical and the only way to help them is diesel therapy, or in this case, jet fuel therapy, or whatever helicopters use. So the best methods for verbal communication to improve radio transmissions is clear, concise information, no codes, inform neurostatus and vitals. When you're communicating with someone, the last thing you need to do is have a communication barrier. I'm guessing since most of you are doing this for your national registry, you guys have done ICS 100 and ICS 700, so you should know the basic principles of communicating to people. Just avoid things that can be misconstrued, not understood. Just make sure, because you got to realize that dispatch is not going to be a medical professional on 85% of the time, so they just need stuff that's clear and they can convey to the other medical providers on the opposite side. Considerations you should have while assessing scene safety of us and others is you and your partner first, then other responders like firefighters, then the patient. You and your partner are always your first priority. You do not want to jeopardize your life, because there's no life saving you can do if you're dead too. You don't want to be an additional victim, so always, if you don't have proper training, hell, if you're just even uncomfortable, it's better to just get someone who's properly trained and knows what they're doing before jeopardizing your own safety at all. When does scene safety start? The minute you start on scene. So that falls under your general impressions in the BSI scene safety. When you arrive on scene, you need to make sure the first thing you do is obviously the BSI and then scene size up. Because if you're walking into a scene, let's say you've got 4 people down inside a house, a neighbor called because they were supposed to get coffee with the mother or whatever, and you walk in, and for all you see bright red patients who are presumably in the first stages of livor mortis, or just lividity, and they're just obviously dead, or they're not at that stage quite yet, but there's clearly some sort of poisoning in the air. With livor mortis for bright red patients, that will be your carbon monoxide poisoning generally. So, but in other words, basically, you don't want to jeopardize your own safety. It's better to take your time and see what's going on. Or like, per se, you're on a construction site and somebody fell off the scaffolding and now the scaffolding's unstable because whatever reason, and now you've got your ambulance parked under the scaffolding and this guy on the ground. All you're doing is jeopardizing everyone in that situation. Who should you contact when down power lines are in any area, regardless of emergency, scene or not? Power company. Power company is the ones who specialize in this shit. There's people who get paid a lot of money to do hard work for that exact reason. So it's better to do the people who are specialized in certain things than have your dumbass walk up, start playing with wires, and electrocute yourself too. You know, so it's better to just wait until you have someone who knows what they're doing on scene. Start triage. Start triage method is widely used for triaging during a mass patient incident or MCI, mass casualty incident, and be able to prioritize each color of the tag and properly treat / transport. So red will be your immediate compromised. So I was trying to find a start card, but I'll just post that up on, like, I guess the community portion, or I'll release a video on how to deal with MCIs, I guess, at some point. But yeah, so red will be your immediately. This is your stuff like compromised ABCs, severe burns, something that's an immediate life threat, and something that they'll die from immediately. This is like your people who have hypoperfusion, or like their cap refills are above 2 seconds. They're having obvious respiratory distress, burns to the respiratory system, etc. Yellow will be delayed. The example I use for this would be like 20% partial depth burn, or like, blisters and shit, but no airway compromise, so they can wait, but they are not normally as able. This can be your broken bones, not long bones, but like your broken arm, for example, things that aren't immediate life threats that will kill them within the next 15 minutes or X amount of time. Someone who doesn't need to be transported to a trauma center or something immediately. Green is your mild. They're walking. This can be like just like small, non-obvious injuries. And just because someone's a green does not mean they have uncontained wounds. So if someone could possibly be hemorrhaging internally, a lot of the time people can throw a green tag on someone and just assume that they're all right because there's no obvious injuries, but meanwhile they've got an internal hemorrhage, they lacerated their liver, there's some obvious damage to them, but it's not visible on the outside yet. Or like a basilar skull fracture with no obvious things and they're walking or some shit. Something that they may not see and may not recognize because the person's AO4 and whatever. So don't think just because someone's green, they're not going to have some crazy life threat that you just can't see. It's always good to err on the side of safety and not grow calloused. Black is your dead, cardiac arrest, apnea. Someone who's just dead. They have clear signs of death like lividity, decapitation, etc. Someone who, no matter what you guys are going to do, they're probably going to die. Or they're dead already. Generally, if it's a living patient, you're not going to put a black card on them. It's better to just move them down, but some people will. And it's not really against anything. It's if someone's apneic and they're in cardiac arrest, there's not a whole lot you guys can really do in a mass casualty incident. When would you, as an EMT, consider breaking vehicle windows to gain access to the patient? No other access, use window breaker but a knife. So if someone's caught in their car and they don't have a broken window, or you can't open the door or whatever, they have clear life threats, etc., you break that window and get to them. Your priority is to help that patient, not sit around and wait. Because you could provide life-saving things, life-saving procedures while they are in their car, and it's better to help them than let them die. When would you, as an EMT, consider calling dispatch for more resources or ordering more units? scene size up is your first phase, obviously, and if you see three or more injuries, such as which would be traditionally called a mass casualty incident, you want to call it what it is. You need more people there. If like there's a massive rollover, let's say if you live in Orange County, you'll know what I'm talking about, like the OC buses, the little small ones, the little whatever, they're like F550s with the party cab on back. One of those rolls over, you're gonna have 20 patients down, and you've got to start triaging, and you got to get more people there because for all you could know, there's people with life threats in there, and all you can do is really treat for one or two of those life threatened people. You need to have more people there. It's always better to have more than none. Um, what criteria does the START triage system use to determine patient priority? Respiratory rate, peripheral pulses, and mental status. So if someone's you can't obtain a peripheral pulse after a minute of waiting, or minute of feeling sorry. So, no radial pulse. Pedial pulses are very hard to find, so that's not something you really need to go after. Respiratory rate, that's something you can see easily most times. If they're effectively breathing, etc. Skin signs will generally point to that. And mental status, if someone's, ANO times 2, they're slurring their words, they've got sluggish pupil, whatever, pupil dilation, or it's stuff like that you got to pay attention to. Dilation or constriction. Um, Next, when and what PPE should be used considering injuries and illness, such as, so in open source, you just need gloves, productive cough, a face mask and gloves, um, active bleeding, gloves, face shield and gown, and childbirth, gloves, face shield, and gown. So when you think about these things, you got to think about what's protecting you and your patient best. So in the case of childbirth, children for I think it's like I forget how many months actually off the top of my head, but a certain amount of months they rely on the breastfeeding of their mom to supply them with antibiotics and enzymes to protect their body. So you have to make sure that you don't spread any infections. That's why you could have some idiot walk into one of these places, cough on the baby, and then boom, the baby's dead. You gotta pay attention because these kids don't have developed immune systems yet, and that's a pretty big deal. Infections can kill them pretty easily. Active bleeding, so hemorrhaging, whether venous or arterial, it's always better to err on the side of safety and put on a face shield, gown, gloves. Think about it if someone's got some sort of bloodborne illness or they've got a communicable disease that can be um, spread through bloodborne pathogen, then yeah, you want to be protected. Productive cough. This is COVID, obviously, is one of the greatest times to talk about this because we're dealing with a disease that, though not traditionally airborne, it's airborne due to particulates. So when someone coughs, I think it's like, well, people breathe in, I think it's like two tennis ball fields of uh, air every moment. So you've got to think about that when you have someone coughing these particulates into the air and you're breathing, two tennis ball fields of person's air in, you're just jeopardizing your immune system. You're inhaling all that oxygen, which leaves you very vulnerable to getting sick. Open sores, you generally just need gloves. Obviously, it varies on some of the open sores. Some can be very bad, some can be just minor. When we refer to open sores, we're normally talking about like bed sores or something minor, not something major. But nowadays, just as kind of a post-COVID deal, you always need to wear your face mask because that's just laws in most states, and it's intelligent practice to follow. During our primary assessment/survey, what emergencies shall be corrected immediately if unstable? ABCs and life threats. So generally, the only life threats you can really treat for as an EMT, or you really will see in emergency medicine, are things like major bleeding. Um, there's very few things, like I guess punctured lungs, um, think it's a cardiac tamponade. I forget that off the top of my head. And that kind of stuff. Stuff that, you know, the person's dying and you have to treat for it. Like, people would think, like, evisceration, spinal injuries, those generally won't kill your patient. You can get them to the hospital and get corrective care. So, yeah, ABCs, no matter what, your ABCs are always your priority, because if someone is not breathing, if someone is not got a patent airway, and if they're not circulating the oxygen through their bloodstream, you're just watching someone die. And it's very complicated sometimes with trauma because ABCs can be compromised by a major bleed, which is also why traumatic cardiac arrest is almost always, or not necessarily traumatic cardiac arrest, but hypovolemic shock will be one of the most fatal things when it comes to a traumatic situation. Um, when can we consider an emergency move of an injured patient? Life threats, ABCs, or immediate threat of death. So if someone's in a burning car, if there's a massive arterial bleed, obviously the same as what was said before. Are we ever able to disturb a crime scene? If so, when? Yes, but only if the patient is alive and needs medical attention. So, um, generally, there will be a police officer standing on scene who will be marking who came in, who left, and they'll just attribute all the things that you left, like IV bags, etc., to what was going on, and that won't really tamper with any evidence. Um, when transferring a patient from a scene to an hospital for transport, what key information is to be relayed to transporting units? Vitals, sample, life threats, ABC, suspected MOI, and NOI. So if you've got a right-sided congestive heart failure patient and it's, they've got, I think, pedal edema and all that kind of stuff, you might want to just tell them that so that they can have an idea of what they're telling the doctors. Sample with the pedal edema guy. He has a prior history of hypotension and cardiac related issues like an MI or whatever. And yeah, that kind of stuff. Or I guess if you really want to go through sample, they've got someone with a let's just do ham. So ham is your pertinent medical history. That will be your, like, as I said, injuries, whatever, allergies. So let's say this guy is allergic to morphine and then medications he's taking, hypotensive medications and cardiac support medications. So this guy's just, hanging in there, that kind of stuff. Sample is important though. So, uh, like E is your event. So what were the events leading up to it? L is last oral intake. P is pertinent medical history. M is medications. A is allergies. S. I honest to God forgot what S is. That's something I need to remember. Sorry, I'll put it right here in 1 second. Signs and symptoms. Well, I guess that falls under general impression, but whatever. Vitals. So if you've got, going back to the same patient, if the patient's got, let's say, 160 systolic over 90 diastolic, and he's got a heart rate of 95 and respiratory rate of 22. That feels off. Well, regardless, yeah. We approach a patient that appears to have a gunshot wound. Oh, fuck it. I've got a better one that I can accurately portray. So, let's say you've got a stroke patient, ischemic stroke, Patient was passed out fucking 2 hours ago. Someone noticed that he was having slurred speech, etc. You come on the scene. You're going and you're doing your Cincinnati stroke scale, all that good stuff. Your sample's going to be signs and symptoms. He's going to have facial droop, arm drift, just right-sided deficiencies. He's going to have allergies to pollen. He's going to have medications that are used for hypertensive regulation. His pertinent medical history. He's a chronically hypertensive patient. Um, his last oral intake was yesterday at dinner, and the events leading up were he was watching TV with his wife. His vitals are he's 240 systolic over 140 diastolic. His heart rate is like uh, 123, and his respiratory rate's 22. This guy's just clearly fucked up. So you want to get him to the near stroke receiving center. Um, we approach a patient that appears to have a gunshot wound to the head. Patient is DOA. What is the next priority? So when you approach someone who has clear signs of death, so as we said, DOA, obvious brain leakage, open skull fractures, that kind of stuff. You see this patient having decertebrate posturing, things that are indicative of severe head trauma, and there's leaking brain tissue. He's apneic, um, and he's pulseless. He's probably going to be dead. I've been told about people who've survived crazy shit, and there's always those one-off history cases where a guy got the piece of rebarb to his frontal lobe and walked it off. I forget the name of that one. But yeah, there's obviously outliers, and that's why we have things like lividity and stuff, but if he's DOA, he's DOA. Your next deal is maintaining scene viability and just making sure that you confirm the death so that people can move on with their day. And yeah, when do we put on our BSI regardless of any patient before we go out? So when you're in the ambulance, some people run the AC so they can get the gloves on easier, whatever works for you. Just make sure you got your stuff on, you're ready to go. Where should we dispose of an EpiPen that has been used? So EpiPens nowadays have a retractable needle, and obviously with a retractable needle that takes away the sharp, but it's always common practice if you're using some sort of sharp implement that has another person's blood on it to throw it in a sharps container, just purely because you do not want to have a piece of contaminated material floating around that can infect someone with a bloodborne illness. When do we consider using restraints on a patient? Only restrain patients when they are a hazard to themselves or others. You're obviously included as others. The most important components of scene size-up is identifying any potential hazards, so trucks on fire, active machinery, whatever, anything that can cause you harm and the patient harm, but obviously you and your partner come first, so that obviously takes your priority. PPE should be worn with a patient infected with hepatitis. Hepatitis is a illness that pertains to basically coughing and bloodborne, so whenever they'll normally cough up like blood. These guys will be needing gloves and masks and goggles so you can prevent any of your orifices from contracting the disease. Our actions if we approach a scene that the patient appears to be a victim of homicide. Documentation and make sure the PD has made sure the scene's safe. When is best to form a general impression of a patient after BSI, scene safety, and what do they look like and what they look like when you're first on scene. So let's say you've got a person whose chief complaint is of respiratory distress. They've got they're cool, pale, and clammy, or cool, diaphoretic, and cyanotic, whatever. Um, and they're in the tripod position, past medical history of congestive heart failure, COPD, whatever. No, not COPD, because COPD requires different treatment, but whatever. And they're having issues breathing. You're going to form your opinions, see what you believe is wrong with the patient, and treat for it. Um, your general impressions, your signs and symptoms can be some of the most helpful things that you'll get on scene, because that can help determine exactly what's going on. So always make sure you're paying attention. That goes into the environment. If you've got like 800 cats around some lady and she's in a fucking hoarder's den, then you're going to make sure that that's that. Because if it's a massive den full of mold and crap, that can easily be a sign of someone having a septic emergency, whatever. There's so many different things that your environment can tell you. And that's why people get drilled penman, because environment after your personal protective equipment is some of the most determining things that you'll get. What is the best way to remove or gain access to a vehicle's vehicle glass? Preferred method for an EMT. So break your rear passenger window. Um, if you cannot open the driver door, you want to prevent any sort of glass getting on the patient if possible, because your number one priority is to prevent any additional injuries when you're on scene. You approach a motor vehicle accident with down power lines. You are asked to I don't even know what the fuck that word is. Off scene, so corner off scene. I'll just say that. How should this be accomplished? Park, isolate, and deny entry with cautious tape. So, signs and symptoms a patient would be exhibiting if there's a suspected chemical weapon. I believe this pertains specifically to things like VX gas and other things of the sort. I forget the name of the compound, one second. I think it's organic phosphates. VX, nerve gas. Organophosphorus class. So, organophosphorus poisoning. This is also found in a lot of insecticides. This is when you can see your duodope medications coming into play, because those can be very helpful, if you will. So sludgem is your salivation, lacrimation, so tearing, urination, defecation, gastrointestinal upset, emesis, and muscle twitching / meiosis. So your meiosis will be your contracted pupils, the pinpoint pupils, if you will. Muscle twitching, generally, jerking, that kind of stuff. Emesis is your throw up, someone's puking. Gastrointestinal upset, so pain in the tummy, they're feeling nauseous. You've got your defecation. So I guess a good way of remembering it is it's coming out both ends. You got your emesis, which you throw up, and you get your shit, which is your defecation. You got urination, so I guess all three ends. But yeah, it's all coming out, and then you got urination. I don't understand completely how organophosphorus nerve agents work, but I'll post a video at some point explaining this, because I'm always interested in that kind of microbiology and pathophysiology of how great humans are killing each other. What PPE and BSI shall you consider when treating a patient with chest pain, productive cough, and just flew in from Africa? Gloves, mask, gloves, goggles, gown. JBL, this book was last fucking perfected around the Ebola outbreak, so this is pertaining to Ebola, back when that was killing the world's population in Africa. So, most effective way to prevent spread of communicable diseases: PPE, wash hands thoroughly, mask the patient. That's what we're doing now. Understand the definition of definitive care. So the issue itself was corrected. So definitive care is generally associated with, you know, a patient has a cut on their hand. Let's say it's a massive cut, they're hemorrhaging blood, etc. You need a tourniquet. And you can't really do much as an EMT. You can clot the blood or put a tourniquet on if it's too bad. And that's all you can really do. You can't really suture the guy up or anything. So you got to bring him to the hospital where some sort of surgeon or doctor who has a qualification certification will suture up whatever needs to be sutured up, close up the hand, give him some antiseptics, whatever, or antibiotics, get him on his way. That's all stuff that basically the definitive care is anything that can be done within a hospital background. So stuff that you yourself cannot do as a EMS provider. Life-saving, life-saving shit. Um, when presented with a DNR, what care should be performed, if any? Whatever is listed by the DNR. So understand these. Implied consent. So implied consent is any sort of unconscious or unable to make informed decisions. So ANO times 2, that kind of stuff. Express consent is when the patient verbally authorizes you to provide treatment and transport either verbally or non-verbally. Circumstances when these apply. So there's many circumstances that all these apply. So if you've got a kid fell off the park, basilar skull fracture, whatever, landed on his head, fucked himself up real bad. It's implied consent that the parent's going to say, well, take my kid to the fucking hospital. I don't want my kid dying a horrible death. Or any sort of situation, 80-year-old Graham fell on the ground and she's dying. You're going to want to take her to the hospital so that she can get her help. Express consent. This can come through with nonverbal, which is brought up. If they're having some sort of respiratory issue, God forbid they're in an abusive situation and you just need to get them out. There's so many different situations where all this can apply. It's all very pertinent on what's going on in the situation. Be able to explain the consequences of a patient that refuses care, especially if the patient is truly in need of patient care. The patient has to be ANO times 4 to sign off AMA, but explain to them the importance of medical aid and the need for help. They could possibly die and or have serious repercussions. So it's always important, if someone's got a life threat, some people may just say, make them sign the AMA, it's not your problem, you're an EMT, it's the paramedic's problem. But a lot of the time, some people, I forget which side stroke it is, but they won't even recognize some pain and they won't understand they're having a stroke, so they can completely ignore it for a large portion of time, and all life-saving care is completely useless at that point. So it's better to take your time, sit down, and explain to someone the jeopardy that they're in, and try and get them to not sign the AMA than just give up and make it someone else's problem. If the patient does not have a DNR at the scene, family states that they have a DNR, how do you proceed and why? Disregard and follow implied consent. Just because somebody's yelling and hollering they got a DNR and blah blah blah, if you don't see it, don't have a DNR to you. You want to give the highest quality of patient care you always can, and just because someone said something does not mean you have the right to assume that they have said thing. You only respond to things that are signed by a medical professional, like all DNRs and postals or whatever they're called. What constitutes a patient being able to refuse treatment? These are criterion that must be followed. Patients ANO times 4, they're conscious, rational, able to make decisions. There is no contraindications to the AMA. There is nothing that would make you believe that they are making a decision that is irrational and would jeopardize them and their safety. So yeah, understand the criteria for us to be able to pronounce the patient dead. Once we do so, how should we proceed? Adults and minor infants, those can be sensitive calls to run. Look for signs of respiratory effort. Does patient respond to pain? Feel for central pulses. Listen to heart sounds for at least 2 minutes. Listen to respiratory sounds for at least 3 minutes. Document that you are confirming the death and time in which you did. Um, it's very good to just general practice to be a nice person and understand that, especially in situations of minors and infants, parents will automatically feel very guilty and very depressed because, I mean, they outlive their children. The sole objective as a parent is to make sure your children outlive you. So it can be very traumatic for these people, and it's always better to take with tact and be very careful with the words you choose. That's why we use words like taken away from us and that kind of stuff, because if you go out and say, oh yeah, your kid got ran over by a bus and they're just fucking dead, dude, you might want to go fucking try for a new one or some just cheap, shitty stuff like that. All you're going to do is cause more problems, and we actually can get down to that in the legal portion of this, where that could cause you a hell of a lot more problems than it will solve. It's always good to just be nice to people, because remember, as an EMT, you're responding to someone in the worst time of their life. So it's always better to just be a great person to people and just care about them, because put yourself in their shoes. You know, a lot of people I know are fathers or mothers. If their child was on the opposite end, they would be destroyed. I mean, everyone who has a kid knows that. It's very hard to have a child die because it's just naturally not what you want to happen. How do we communicate effectively with a patient in distress that's not speaking English? Do not treat them like they're stupid. Figure out how much English they speak. Use short, simple phrases and questions. Use translator app or find someone to translate or request a translator if possible. Um, in Southern California, especially, there's a lot of people, for lack of an example, when I worked in construction, this fellow fell down from I think it was like 10, 20 feet, and he partially eviscerated himself and started seizing once he hit the ground. When we called the EMTs, I don't believe any of them really spoke English, so they had to kind of rely on a few of the fellows there at the site who translated what was going on. The guy was unable to speak English, but he was conscious, so they had to figure out a way to communicate with him somehow. But obviously, with a trauma situation like that, there is always going to be more focus on life threats than figuring out all the medical history. But it's always good to do that. Actually, there is no reason you shouldn't do that. It's like vitals; they're always important. So that can completely determine what's going on. Think about how you should describe to a patient the pathology of why they're having chest pain. Please ask. It's your job to answer and understand as a competent EMS professional. So muscle strains. Muscle strains will be your inflammation. They will be your tears in the muscle, that kind of stuff. So the pain is due to the inflammation pressing on nerves. Persistent chest pain can be a wide variety of things, so there's a lot of different reasons why. Injured ribs goes back to the inflammation issue. Peptic ulcers, inflammation, and introduction of fluid into spaces that it's not supposed to be. GERD, that goes back to the acid reflux issues where they're melting away portions of their body that isn't supposed to be exposed to bile, so it can be extremely painful. Asthma, asthma is basically where your bronchioles constrict and they're unable to transfer oxygen, collapsed lung, or basically there's air or blood into your lung and it's unable to breathe the same that it would if it was unjeopardized. It's basically blood and air filling up your pleural space, making it harder for you to believe. Myocardial infarctions or heart attacks, those are basically the cells in your heart are dying, resulting in failure of your heart to beat properly. So there is basically a lack of blood being pushed through your body. When assessing a patient you are trying to obtain pertinent medical history, what is the best way to ask for these questions? Encourage patient to talk more, give them time and space to think what they want to say, be sensitive to their thoughts and feelings, clarify answers. How can we communicate effectively with deaf patients? Face them if you can. If they can read lips, write things down, facial expressions and gestures always help. Why is it important to reassure patients when asking pertinent medical history? To make sure you get accurate information, someone's not freaking out and giving you information that isn't helpful. What type of consent would be considered if a patient is verbally giving you permission to treat them? Express consent. What is the best defense in court with dealing with your patient care report or documentation? Write everything down, leave nothing blank. What is a standing order that is issued by a medical director? A pre-written medication order and specific instructions from a licensed independent practitioner to administer a medication to a person in clearly defined circumstances. So this can go all the way through a lot of things, prescriptions and stuff. What is a reciprocity in regards to maintaining your license? So, um, let's say you're in California and you want to move. I don't remember. I think it's like Maine or some shit. You can move there, and you have the ability to transfer your state license through the MNRMEMT. So libel is a written defamation, slander, spoken defamation, perjury is an intentional act of swearing a false oath. Vilification is abusive, disparaging speech or written. Um, so basically, you can't just cuss out a patient or be a piece of shit. So, be nice to people and, scratch my back, scratch your back kind of stuff. Um, if a correction needs to be made to a patient care report, how do you make a correction? Make the correction in a way that preserves the original entry, draw a line straight through the erroneous entry, and write the time and date and name. Identify the reason for the correction, include a rationale in your notation, for example, mistaken entry, wrong medication written. What information shall be omitted from patient care reports when we are using as a training document? That'll be your name. And what is a CISD? Critical incident stress debriefing intended to prevent or limit the development of post-traumatic stress disorder in people exposed to critical incidents. So let's say you have a kid who got fucking beaten to death by their father and they're half strewn about the house, leaking brain fluid or whatever. You're going to probably end up talking to somebody to just talk, because a lot of the times that will help people, and it's very pertinent in the medical field, especially first responders, where they're seeing some of the worst things that humans can do to each other, to just talk to someone who's willing to listen, because a lot of the time that can help a lot more than drowning yourself in a bottle of booze. So, yeah. Thank you for the video. I hope this helped you. Or thank you for watching the video. I hope this helped you. If you have any questions or need additional information, feel free to write it down in the comments, and I will gladly get back to you and help you out. If you heard any information that is incorrect or I should adjust, please inform me, and I will gladly make an adjustment when I have the time. Thank you.